Hi dear, good afternoon.
Good afternoon, John.
So,
Hope you are doing
how
good.
is it going today?
Yeah, I'm doing good, Anjum. Thank you.
Okay, so may I know your experience in medical coding?
Yes, Anjum, sure. I have total experience of 5.5, close to 6 years of total experience, and in which for like past 12 to 13 months I have been working in IPDRG, and the previous ones were 7 to 8 months in HCC coding, and the rest are in the home health medical coding. So
Perfect.
yes, that's it. Like the complete experience for my home health, sorry, medical coding career.
Okay, what are the certification you have?
Currently, in active certification, I have the CPCA, and for the BCHHC for home health coding. Both are
Okay,
active currently.
okay. So, which certification you have done initially, means CPC or home health certification?
Now, as I started my career in home health, so it was the first BCHHC. It was the first, and in I guess in 2020 I did the CPC. 20 or
Okay.
19 end, I think.
Is there any plan to do additional more certifications?
Yes. Like I'm planning to continue my like further career in IPDRG, so I'm planning to do CIC like in
Okay. Why
future.
you choose CIC certification?
There's no particular reason, but since I have CPC, it would be an added advantage, and certain rules which I currently don't know much about, but CRC and CIC have particular separate rules and regulations which I know. So in that aspect, and it will be more easier for me to maintain the certification along with CPC.
Okay. So now coming to the points for
Yes.
IPDRG interview questions.
Sure.
So what is the clinical indicators?
Clinical indicators are basically, say suppose for a particular diagnosis, like the clinical indicators are the symptom for that particular underlying diagnosis, for by which the doctor, the physician, detects that the patient might have that condition. Say suppose the patient has a sepsis, but for the primary indications that the patient will have like fever or
Mhm.
restlessness the patient might feel, and respiratory issues the patient might feel, and weakness, of course, weakness will be there,
Mhm.
and so like so the weakness and fever, we might say these are the clinical indicators for the sepsis diagnosis, like that.
What will be the additional clinical indicators for sepsis apart from fever and weakness?
Fever, weakness, and RBC count, like white blood cell count, might go up, and so that would be the pathological indicator actually. And what else? Okay, yeah, headache will be there. Headache will be there, and weakness I already told. What else?
Okay, now the next clinical indicator is UTI. What will
Okay.
be the indicators for UTI?
Mm, the primary will be the burning sensation while urinating, and fever will be there if like UTI is been there for few days, like for a particular time frame, and so fever will be there, and burning sensation, and dysuria might be there, and if the UTI is severe, then the patient might have a hematuria, and mm, most of the clinical indicators are this only for the UTI.
Okay, what is the clinical indicator for pneumonia?
Pneumonia. For pneumonia, common is the fever and breathlessness. Like the patient might feel like that the patient is running out of oxygen, and cough in lungs, of course, and the phlegm will be like greenish in color mostly if the infection is there in the lungs. And breathing, sob is there, sob will be there. And
Mm-hmm.
what else? Fever I told already. And mm, 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 mm. That might be it actually. I don't think that will be more.
Okay. What is UHDDS?
UHDS is like the full form, if I say, like Uniform Discharge Data Set. So it was designed to particularly to make it fair for all the hospitals and patients for the like fair payment system kind of.
Okay.
So hmm.
What are the guidelines will be there in the UHDDS?
Guidelines as in like guidelines as in you are asking like selection procedure of the for the like that.
Correct. Selection
Okay.
of principal diagnosis,
Okay,
principal
okay, okay.
procedure.
Yes, yes, yes. So a selection of principal diagnosis is there for the UHDTS. So basically, the patient is coming with the all patient is mostly patient gets admitted with the symptoms only, right? So patient does not know the diagnosis particularly. So diagnosis, so the admitting diagnosis will be the symptoms mostly, and after that he will be diagnosed by the like emergency like ed physician or the admitting physician, that the patient has suppose the patient has a pain, so pain will be the admitting diagnosis, and the patient was then diagnosed with say suppose fracture, so fracture will be the principal diagnosis. So these comes under the USDTS, and then there are separate secondary conditions which the patient might have, like like in comorbid conditions like before hospital that admission. So this comes under the USDTS.
Okay. So what is comorbid? What is the definition of comorbid and morbid?
Comorbid conditions are the conditions which were there like even before the admission of the patients. So say suppose the patient currently was admitted with sepsis. So sepsis is the like principal diagnosis, and the comorbid conditions the patient had was the hypertension and diabetes. Say suppose the patient had these diagnoses for like years, like few years, and he has been taking medications for that. So this will be the comorbid conditions, and this might or might not affect the principal diagnosis. So these are the comorbid
Are you sure
diagnosis.
about will not affect
Yes,
on the principal diagnosis?
it might affect and it might not affect actually.
So are you sure about this definition?
Uh, if you go like to CC and MCC perspective, then that might affect. But
Yeah,
the
that
conditions,
thing only I'm asking. What is comorbid
yes.
and what is morbid conditions?
Uh, so see, the comorbid conditions are these only, the existing conditions for the patient. So if I say, suppose the diabetes, if the patient had a diabetes, and coming to IPDRG perspective, then if the diagnosis of diabetes is affecting the primary, like the principal diagnosis, then it is important. Like it will change the DRG values for that. And say suppose diagnosis like GERD or hyperlipidemia like that, so that might not affect the DRG values. So that's why I said it might or might not affect the principal diagnosis.
Okay. What are the things that will be affecting on the DRG?
mm, DRG, MCC and CCs are there, and apart from that sometimes it discharge disposition might affect. And
Okay.
because if the only example I remember is if the suppose the patient was admitted with infarction, myocardial infarction, and for if suppose the patient died in the hospital, like the patient like could not survive the attack, the myocardial infarction, so that might affect the DRG value. Like the DRG value of the survival and the death will be different.
Okay. Have you ever coded the PCS in IPDRG?
Yes, yes.
Okay. So what is the PCS characteristics?
PCS characteristics. Okay, so IPDRG basically frames a seven characters PCS code, in which one is first, the first one is the section, and then it comes to the body system, then it comes to root operation, then it's the body organ, and then what approach the patient, the physician took to treat the patient, and then comes the device, what device has been used, and then the qualifier. So this consists of the set of this PCS code.
Okay. What are the procedures you have coded in inpatient?
Uh, Mostly we dealt with replacements, fractures, like that only. So the ortho part mostly.
Okay. In orthopedics, what are the procedure you coded?
Like replacements, so root operation replacement was there. So like the patient came with a knee replacement, so it was there. And as suppose fracture, so for fracture we used reposition. Reposition is the one root operation.
No, I'm asking about the procedures, not the route of operation.
Okay, so yeah, the procedures were fractures and replacements. These were the procedures.
Okay. Have you ever coded fusion procedures?
Yeah, once or twice, yes.
Okay, so what is the definition of fusion procedures and what are the guidelines we need to follow?
As of guideline, at the top of my mind, I know that the fusions are whenever we are coding fusion, the laminectomy, foraminectomy, and foraminectomy, and I can't remember the third one. These are included in the fusion procedure. If it's the same, the same disc the patient has been treated, and the discectomy, we code it as a separate code, like separate PCS code for the discectomy of the any region.
Okay, so it
So
will not part of PCS fusion, right? So
no,
you need to
discectomy
code
we
this.
have to code separately. Yes.
Okay, sure.
Yes, yes. And the
Okay.
fusion is the immobilizing the any two joints or any two vertebrae to treat separate conditions like stenosis, radiculopathy, like that, DDD.
What is the occlusion and restriction?
Occlusion and restrictions are two root operations which are used to occlude like a total. Okay, see, the basic difference is occlusion is the total blockage of any, like what can I say? The example will be tubal ligation. Say suppose the so this fallopian tubes are totally clipped for this. So the like. I cannot describe the procedure actually, but this is the example basically for this occlusion. And say suppose if the banding procedure has been done for Dobie's patient, and
Mhm.
that will fall in the restriction. So restriction is a temporary basis, and occlusion is for the permanent. It's a permanent basis, like that. This is the basic difference between these two.
Okay. And what is CABG procedure? Have you coded a CABG?
CABG, yes, I have coded. Yes,
Okay.
coronary artery,
Just give me
that's a
the
bypass.
detail of CABG guidelines.
For CABG guidelines, guidelines as such of guidelines, I don't wait. CABG. See, the bypass is the main route operations used in that for the CABG, and there are separate If yes, I one guideline I remember. If the graft used in CABG is taken from Rima or Lima, that won't be coded as separately, because that's the because that particular part has the physician has to be cut, like the physician has to cut that part, and the Lima and Rima will be like accessible in that particular procedure only. So we do not need to code Rima and Lima grafts separately, but apart from
Mhm.
those two, we have to separately code harvesting, like harvest of that graft. Say suppose the Stephanus vein graft has been taken for CABG procedure, or like radial artery has been taken, so that we need to code separately with a harvest of the graft code. And origin of the blood, like the bypass flow from where the graft sorry, the route has been taken to supply the blood to the arteries, coronary arteries, that
Mhm.
matters in as a like as a procedure. And what else what else atherectomy atherectomy has to be coded separately. Yes, atherectomy has to be coded separately. If
Okay.
done, if done, atherectomy has to be separately coded. And mm, that's it. That's it. I can remember. And the and the same thing regarding your like previous question. The same thing I forgot to tell. This fusion. If the graft has been taken from any other region, in from where from like from the site of the procedure, that has to be coded separately for harvesting. Say suppose from sternum they have taken, or the graft, and or say suppose the cervical fusion has been done and the bone graft has been taken from the lumbar section, so we have to code that. Whenever the physician has been like has separately incised any particular region to harvest a graft, we need to code that separately.
Okay. What is the recent coding update for ICD-10 CM?
Acetyltensium, recent in 2025, recently has been, yeah, they have updated the DDD codes, like discogenic 56, like suppose for lumbar it is M5136. It was previously used to be 36 only, so for now they have separately code for discogenic back pain as well as the unspecified one. And what else they have updated? Obesity, yes, obesity code they have updated. Now they have classes which we previously didn't have, and we previously used to have unspecified obesity and the morbid one. So now they have particular classes like 1, 2, 3 by codes. And what else? I think vascular dementia also has been updated. mm,
Okay. What is the COVID updates?
COVID, recently they didn't update anything. The last update was that U09 only. U099.9 for the late effects of the COVID, and U07 for the active COVID.
Mm-hmm.
And for history, we used to code Z8616, like that, the patient having a history of COVID.
Okay.
That's
What is the
that.
guidelines we need to follow for myocardial infarction?
Myocardial infarction guidelines. That has only
Yes.
one guideline actually. For like we cannot code myocardial infarction as active after like post 4 weeks. We have
Mm-hmm.
to code like history, or like sorry, old myocardial infarction, like post
Okay.
4 weeks. Okay, yeah, one more guideline is there. Like in between 4 weeks, if the patient had another infarction, that there is a code for that subsequent infarction for that. That is one. And also one, yeah. Oh, well, I don't remember that too. For like, say suppose the patient had like there's a known like no documented like infarction for both STEMI and non-STEMI and STEMI. We have to code STEMI because it's that's the more severe one.
Okay. Okay, dear. So thank you so much for your time and joining for the interview.
Thank you,
So
Anshul.
I will share your feedback. I hope you enjoyed the interview.
Sure,
So
sure, sure.
thank you for your time.
Thank you for your time as well. Thank you, Anshul.